AIOC's RP Center. He has done immense work in strabismus and different kind of novel imaging modalities. So today he's going to give deliver a lecture on AIOCT in strabismus.
Good afternoon, everyone. Thank you, Dr. Deep and Dr. Sujit. So we'll be discussing how to decode or how to identify what are the different roles of imaging in strabismus and how we can use different modalities so that we want to ultimately percolate all this knowledge to plan something in strabismus which should be meaningful and which should satisfy the patient. So in this manner, I will be talking about AIOCT and minimally about UBM because I have mainly worked on AIOCT. I will try to show how to identify the muscle in different scenarios and how to use that knowledge for your surgical planning. So why AIOCT or UBM studies are necessary? Because mainly we operate on the anterior portion of the muscle, right? We never operate on the belly or the in origin part of the muscle. We mainly operate on the incisional part of the muscle. So but your CT scan MRI, they are not able to identify the anteriormost portion of the muscle. But AIOCT can do that, even UBM do that. So pre-operatively, if you are able to do it, can we get some kind of sensible knowledge which can be used for surgical planning? So that is my research question, right? So if you search for the literature, you'll get on 20 to 25 studies on AIOCT in various forms of strabismus, but 15 to 18 studies are mainly focusing on how to identify the normal muscle. That is quite kind of useless because if you say I can see your muscles normally, so it doesn't make any sense. If you are able to say in complicated cases I can see the muscle, I can plan, then that makes some sense, right? So how we can use the AIOCT for muscle surgical planning. So I will begin with the normal muscle, how to identify. I want to tell some of the features which have not been described earlier. So this is extremely adducted eye, that is your elevated eye. This is adducted eye, so that is abducted eye, sorry, and that is depressed eye. So that is for medial rectus imaging. You want to take patient to extreme abduction. So there you can see this is a muscle, right? So obviously when you are looking for the ocular coat contour, you can see the ocular coat is very crisp and clear. It is convex, perfectly convex. There is no irregularity, there is no scarring. So this is how the naive or unoperated eye looks like. So if you want to look for the muscle, you should be looking at a 50% depth, not superiorly or not quite deep also, right? You can see here. And whenever you're looking for the muscle, muscle begins as a tendon. So it is a thin hypointense layer which is going to assume a darker or thicker configuration. So that is transition from muscle tendon to the belly, right? So this is medial rectus and this is inferior rectus. You can see it is a slight tendinous portion which is becoming more of a belly, and the same applies to even lateral rectus here, right? And the same applies to even the superior rectus. Superior rectus has more bulkiness. That's why we are able to see a belly. So this is how we need to identify the normal rectus muscle. So to use it in an operated eye, let us assume that this is anterior ocular coat, that is between the angle and the insertion of the muscle, and beyond the insertion let us assume this as a posterior ocular coat, right? So here you can see, if you ask me how much or what is the extent of maximum extent of visibility, so if you are able to extremely adduct, you can see that the muscle, here it is tendon, it is becoming more of a belly. You can see up to 8 to 9 millimeter of the muscle, anterior portion of the muscle. So similarly, this is angle and this is lateral rectus insertion. This is how we can see around even 10 to 11 millimeter of lateral rectus tendon. Here this is for inferior rectus and superior rectus. So how to identify the operator muscles? As I said previously, if you look into this picture grossly, it appears that it is a disturbed globe or disturbed ocular coat. It do not have a very crystal clear convex contour. So you can see that it has a scarring here, right? So it has thinning and thickening, right? So obviously it is an operator eye, it is not a naive eye. So as we anatomically read, the sclera is going to be thinnest just posterior to the muscle insertion, right? So this is a probable muscle insertion where you are going to see the scleral hump, right? So followed by there is a thinning of the sclera. So this is a recessed part, but I cannot see muscle anywhere here. So I can see here beneath the conjunctiva, and but this is not the artifact which is projected by conjunctiva. I can see a definite hypococ area. It could be muscle. I'm not saying it is muscle, but I can measure from the angle and I can say it is around 10.8 millimeter. So similarly, do the medial rectus imaging of the other eye, then we'll get to know if that is at 5 mm or 4 mm. You can deduct 11 minus 5 mm, so probably 6 mm recession has been done, right? So that's how we are going to identify and confirm intraoperatively muscle was recessed. So this is how we are going to identify the resected muscle. Again, you can see congenital scarring. The contour is not like a naive eye, right? So again, it is disturbed, probably it is an operated eye. That's how we are going to say. Then again, you can see the muscle not appearing as a hypointense small thin layer. It is abruptly appearing as a thick hypoechoic layer. So probably tendon has been resected. So this is a resected medial rectus muscle. So this is for lateral rectus muscle. So you can see the sclera has become more undulating because once you operate the eye, the ocular contour, so ocular coat loses its naiveness, its contour, right? So similarly, you can see this is a probably original hump. After that, the coat has become more undulating, and you cannot see any continuous single hypocochlear layer. So obviously, the LR is not there till 15 millimeter from the angle. So you can image the other eye LR. So that could be around 7, 7.5 or 8 mm. Just deduct 8 mm from 5, this thing 15 mm. So probably 8 or 9 mm of LR recession has been done. So similarly, you can see the muscle is quite thick here. There is no tendon. It appears to be belly. And image the other eye LR. So if other eye LR is at 7 or 7.5 millimeter, you can say that this muscle is at normal position, but belly I can see. So that is a resected muscle, right? So these are other injuries, like this is traumatic muscle slippage. You can see the muscle has gone posteriorly. You cannot see any hump here because it is unoperated eye, but trauma was there. So we want to open for the first time. So ocular coat has been not been disturbed because it's not operated, it's a traumatic eye. So muscle has slipped posteriorly. There is a partial slippage of the muscle, and some fibers were attached to the insertion, which I'm not able to see on OCT, but intraocularly it was there. So similarly, you can see this scarring again, right? So muscle is traumatically, it is edematous. So that's why we're able to see a thickened contour. This is thyroid eye disease. In thyroid eye disease also you can see how the muscle and the tendon, even the thyroid eye affects the tendon. You can see thickened muscle tendon as well as belly, right? So these are some other unusual case scenarios. In usually cephaloma or other sensory exotropia, we are like hesitant to operate because if there is a cephaloma, if you open the conjunctiva, there is a chance that evil tissue prolapse might happen and patient end up with like hypotonous globe, which patient will not accept, right? So this is one scenario where post buckling there is a lost inferior rectus is there. You can see the ocular coat is ectatic, right? So it has been operated twice, once buckling insertion, buckle removal, and after that IR got thinned out and there is a lost IR. So here you can see this is a minimal ectatic, this is mildly ectatic, this is severely ectatic. You can see, I can see muscle here from here to here. So this is muscle is not incarcerated at the ectatic point. It has been pushed posteriorly. So we can go through the fornical route here. We can suture the muscle and we can recess it just to correct the exotropia. And similarly, in one of the SFL, what happened is we are doing screen surgery, but unfortunately there was a damage to the haptic portion. So after that, we started imaging these muscles, also these eyes, and you can see this yellow point arrow. This is a plane of the haptic, SFL haptic. I can see this LR is here. So the safe distance is on 5.3 millimeter. So I have enough space, right? So I can just recess or even plicate this muscle. But here you can see the LR is thin, MR is thin, and it is originating from here. I mean, it is inserted here. And if you measure the distance between haptic and the MR insertion, it is quite less, 2.8 millimeter. So anybody can hear, it's like size of a pupil. So you can potentially damage the haptic. So you can give this case to senior, or you can just explain it to the patient. It will be quite this thing, right? Challenging. So these are the 10 cases where I did imaging, where patient have completely lost their details. They came to us with undercorrection or overcorrection. Now they have residual deviation. You have to correct it. Previous surgery, we don't know. Just get a ASOS done. You are able to say something. Yes, probably muscle is here. You may not be able to say resection 6 mm has been done or 5 mm has been done, but you can say probably resected muscle hai, usme mat kar lijiye. You are not going to get anything by operating in that eye. So these are the 10 patient details, what were deviation, how many times surgery they have undergone, and what about the congenital scar. You are able to see on both sides, because if patient has undergone surgery 10 years back, you won't be able to see that much congenital scar. And that too, we do fornical based congenital surgeries. So again, the fornical scarring will be there, but the global scarring won't be there. So again, it is like bit challenging, right? So if a young patient is there, healing will be good. Old patient, definitely scar will be there. So what are the deviation? What are the ASOST findings? And intraoperatively, where I am able to get the deviation, I mean muscle insertion, and what was the approximate distance? I felt that like 0.5 to 2 millimeter within that distance, I can predict the muscle insertion, right? So in conclusion, in strabismic eyes, the ASOT can be used in preoperative period for optimal surgical planning as well as visualization. The limitations are like ASOT imaging and strabismus. It is an evolving tool. So we are going to find out 20 to 25 studies. We need to evolve. Everyone needs to do it because these are my findings. If you do it, you will find some other findings, and that's how we are able to mutually give more findings, right? More understandings. So subjective variations are high. So you can say this is probably not muscle. I can say this is probably muscle. So that kind of subjective variations will be there. So it is not about whether you are right or I am right. So let's open the conjunctiva. Let's see how it appears, right? So this is first paper I published on like ASOST, when there's a surgically lost details, how we can use that particular ASOST for surgical planning. And secondly, till now in last 3 years, I have imaged around 1104 muscles, 1104. And in that one, I was able to define in what all the conditions we can use the ASOST. So it is like resurgeries, whereas when undercorrection, overcorrection, slip muscle, traumatic slip muscle, ocular ectasia, or SFL muscle, these cases, rectus muscle hypoplasia, aplasia, right, thyroid eye disease. So many conditions are there. You can get some sort of information right now. So in future, we are going to carry out more observations and we'll be able to tell more accurately. And in future, there is one article in PLOS on where, like, that is Japanese study. They have done n-fast imaging. They are going to take 10,000 scans, and the machine artificially predicts the hypoechoic area, muscle. So that is able to create a virtual image of fleshy part on the sclera itself. So it is like you are going to take a snap and you are going to say that muscle is probably here. So that's how the technology is going to change. But as of now, we are here right now, right? So in future, we hope that as we image the MGD, if you take the image, you are able to map the Mebane gland. So in future, if you ask the patient to adduct and you are going to screen the lateral sclera, you will be able to see the muscles there only. It's recessed, resected. Then you can use a caliper and you can measure the distance. So that could be the end point, and that will be a good thing for a strabismus surgeon, right? We can see visually where exactly muscle is, and it will be very useful in surgical planning. And at the same time, we can counsel the patient, this is your muscle. Because for government practitioners, for us, it is okay because patient has so much faith. But for private practitioner, it will be very difficult to counsel the patients. So if you ask the patient just to have a look at your scan, so patient will be more confident, yes, what your doctor is saying. So that is pretty much true because I cannot see any muscle myself here. How can he see? So obviously doing any surgery in that eye will be wrong. So that's how we can gain more confidence of the patient and we can do more justice, right? Thank you. Yes, please. Yes. Yes, yes. These are the questions most commonly asked. I didn't mention that in poster session. People ask me this question. Pseudotendon is basically, if you understand the composition of the pseudotendon, people say that like the suture got stretched, in between there was some kind of tendon which got replaced, which is acting as a bridge. So actually muscle is behind, that is a tendinous portion. So obviously any tendon, any conjunctiva, that is going to be a white thing, right? So as I shared the second thing, the LR resection, right? So that was MR resection. That was at 8.4 millimeters. So obviously MR cannot be at 8.4 mm if I was saying resected. So it has to be between 4.5 to maximum 6 mm, right? So that is a pseudotendon. The pseudotendon is nothing but a tenon that is going to be homogeneous only or white only. It cannot resemble like a black muscle or a hypointense layer. So you cannot make it recess muscle. Obviously, in if you are expecting a pseudotendon, it appears as a ocular coat only, white only. Exactly. So, but whatever the muscle is saying, say for example, your muscle is actually at 8 millimeter, but you are able to see hypoechoic area from 10 millimeter onwards. You will open conjunctiva, you will see 2 millimeter of tendon, but I cannot say anything right now regarding that one. But yes, it resembles like a normal sclera or normal tenons only. That is error. Exactly. Exactly. Thank you.
Any more questions? Okay, now I would like to invite on stage Dr. Sujit Moyabidna. He has done senior residency in oculoplasty and strabismus from RP Center Ames and has immense experience regarding management of strabismus. Currently, he's practicing as a consultant in Vision Eyes Hospitals in Hyderabad. So, Dr. Sujit, you can carry on.
Thank you, Dr. Deep. Uh, Good afternoon, everyone. I'll be discussing about imaging in strabismus and amblyopic eyes. Basically, imaging in we routinely don't do imaging in strabismus until unless there are specific indications. So these are the common indications. Like whenever there is an acquired sudden onset cranial nerve palsy, which is progressing, which is not stable. Usually in elderly, whenever see cranial nerve palsy, we attribute it to either diabetes or hypertension, right? But if it is progressing, then we think of any vascular conditions like that. And in the case of trauma, since the ASOCT is advancing, maybe this indication can be replaced. But for the purpose of identifying any fractures, lost muscle details, we can do imaging. And in cases of complex strabismus cases where there is diagnostic dilemmas and dysmorphisms and in developmental delay, whenever you want to plan your surgery, you can if there is any doubt and if the strabismus is complex, you can do imaging. Otherwise, for the research purpose also, you can do the imaging. So these are the conditions in acute onset non-accommodative esotropia, routinely we see in children or in adults. Whenever there is sudden onset committant esotropia, we do imaging to rule out this cerebral astrocytoma, medulloblastoma, any intracranial pathology basically. If you don't find any intracranial pathology, then you can plan the recession surgeries. And cysticercosis is usually, people don't think of this disease, but it is a very great mimicker. It can present as a peripheral, it can present in the peripheral muscle, or it can even present in a intracranial, intracranially causing a third nerve, sixth nerve, or peripherally it can present causing a LR palsy or superior oblique palsy, or it can even present as Brown syndrome. So this is an image showing an MR cysticercosis. As you can see, this is a MRI T2 image where the cyst is appearing as hyperintense. And a simple instrument which you can use for diagnosis of cysticercosis in the orbit is an ultrasound. As you can see, there is a scolex. If you do B by A scan, the scolex will appear with high echo. And even CT can identify the cysticercosis. And as I said, in extraocular muscle trauma, you can identify the fractures, either floor or medial wall. In the floor, you can see whether there is entrapment of any tenons is there, or whether there is entrapment of only muscle is there, and plan accordingly. Here you can see there is a medial wall fracture, and here you can see there is a complex, even lateral wall fracture is there. And since Deemer has introduced the term of pulleys, there is whenever there is a disorder of pulley, you will get an A or V pattern. This is mainly for research purpose. Initially they have done. As you can see in the A pattern, there is upshift of LR and nasalization of SR, and in V pattern there is temporalization and downshift of SR and LR. And you can, this is an important condition where you can identify by doing an MRI, sagging eye syndrome and heavy eye syndrome. Basically both the patients have myopia. But how do you differentiate whether it is a sagging eye syndrome or heavy eye syndrome? Basically there is no appreciable prolapse of globe. This is a sagging eye syndrome. You can remember it as S for S. There is soft tissue prolapse. You can see the globe is in center, but since the soft tissue fat and lacrimal gland has prolapsed, there is a disturbance between the LR and SR tenons. And in heavy eye syndrome, since the globe has prolapsed, most likely there might be staphyloма, there is a disturbance in the SR and LR tenon, intermuscular septum. And moreover, in the sagging eye syndrome, Yokoyama procedure is routinely done, whereas in heavy eye syndrome, you can get away with by doing an augmented medial rectus recession. Similarly, in congenital cranial nerve palsies, you can identify the, in case of congenital superior oblique palsy, as you can see, this is a normal superior oblique, and here it is in the shape of fusiform shape. If you compare the both, you can see this is normal in volume and size, but it has reduced in size. And here you can see there is, if you have a normative data, you can directly correlate it with this. The size appears to be lower than that. And this is a normal eye. You can see the bulk of the muscle is almost symmetric. Similarly, in sixth nerve palsy also, you can see the LR muscle is quite thin compared to the other eye LR. And one thing is, in Duane's retraction syndrome also you can do imaging, and as you can see, this is a bilateral Duane's. Basically for this you need a high resolution imaging. Nowadays I think 6 Tesla MRI has come out. So if you do that, you can identify the nerves, cranial nerves, whichever innervating the muscle, you can identify. This is obviously this I have obtained it from articles, and these are poor quality, but here you can make out a fissure kind of thing. This is a bilateral type 3 Duane's. And similarly, intracranially, where the sixth nerve arises, you can see there is an absent nerve here, and there is the presence of nerve over here. And this is sometimes a patient will come, he's an elderly patient, he will come with a presentation similar to sixth nerve palsy, but he doesn't give any history. He doesn't know whether it was present since birth or he suddenly acquired it. He doesn't give any history. So you can do imaging in that cases to identify whether it's a Duane's or six-nerve palsy. Essentially in Duane's, the muscle bulk will be normal. Bulk will be normal. But in six-nerve palsy, the bulk will be reduced. I think with the advances in OCT, even this indication will be replaced. And similarly, whenever a patient comes with a complaint of torsional diplopia or limitation of elevation in adduction, simulating Brown syndrome, you want to find out why Brown syndrome has happened suddenly in adult. So you can do imaging to identify any sinus pathology. You can easily identify any sinus pathology in MRI. So if there is any sinusitis, if you treat for the sinusitis, the condition might resolve. If it hasn't resolved, then you can give directly triamcinolone injection in the superior oblique region to reduce the inflammation. Similarly, this is a case of NSOID, non-specific orbital inflammatory disease. You can see there is a intense inflammation in the orbit. So these are the few of the indications which I have shown in the strabismus. These are just not those indications. You can even do whenever you see any complex case. So imaging in amblyopia, it's really a research, just for research purpose. If you are really interested in finding why amblyopia is happening, what is happening in amblyopia, then you have to go for functional MRI, which is a very complex imaging. You have to know the idea of what are the vision centers in the vision, how is the vision processed in the brain. Then you have to learn about functional MRI, because these are all the various techniques. Initially they used to do diffusion weighted imaging, then diffusion tensor imaging. Then these are the sequence in which the functional MRI has evolved. These are all the algorithms and techniques with which they acquire the functional MRI. So there is a MR spectroscopy, there is blood oxygen level dependent sequencing, there is voxel based morphometry. I will show you in subsequent slides how the images appear. So these are the vision processing area, primary and secondary vision centers and accessory visual areas. So first you should know the anatomy of where the centers are located. Then only you can go ahead by doing for researching in the amblyopia by doing functional MRI. So this is the earliest imaging done in, I think, in 1990s. Earliest was PET CT scan. As you can see, there is decrease in uptake in the primary visual cortex area. And here you can see this is a normal eye, this is an amblyopia fixing, and this is a normal eye fixing. You can see there is a decrease in uptake of by doing PET scan. They identify the primary visual cortex is defective. This is earliest finding. Then they identify there is role of lateral geniculate nucleus apart from primary visual cortex. Here you can see this is a normal eye and this is an amblyopic eye. Here you can see there is normal activity, but when he's fixing with the amblyopic eye, there is decrease in activity, probably because the LGN is not getting activated, so there is a decrease in activity. And similarly, they have even done the modulatory. This is a modulatory feedback connections where V1 are responsible for morphological reduction in lateral geniculate nucleus, thereby modifying the input of binocular cells in V1. So here you can see this is the normal eye fixing. Whenever there is a normal eye fixing, there is normal modulation is there, but whenever there is an amblyopic eye fixing, there is decrease in modulatory effect. Next, they identify even calcarine sulcus is also having a role in amblyopia. There is decrease in the size of calcarine sulcus. This is a normal eye, and you can see the amblyopic having decrease in the calcarine sulcus. So they identify that in anisometric amblyopia there is a defect in high spatial frequency, and in strabismic amblyopia there is defect in low spatial frequency. Then they identify the V2 area surrounding the V1 area. Even there is reduction in the V2 area. Initially I have showed you the normal anatomy. So V2 area will be surrounding the V1 area. So this is the V1 area, this is the V2 area. Initially they thought only this one there is pathology over here, but later they identify even in V2 area is also there is pathology. Then patching has been done since before functional MRI, but by doing a bold sequencing, they identify that complete patching of the right eye can have, you can see there is a there is decrease in basically if you don't patch the normal eye will inhibit the amblyopic eye. So if you patch the eye, the negative bold value is low. Okay, so this they identify even with by doing a functional MRI. Then they have done phase encoded retinotopic maps by doing a cut along the horizontal meridian of V1. Basically, they even sliced the V1 by doing a, just like how we do pentacam, they have done similar color coding over here, so that to see the functional activity over the V1 area. And they identify the reduction of responses to stimulation of amblyopic eye in V4 and V8. This is a voxel based morphometry where they have seen that there is not only the lateral geniculate nucleus and primary visual cortex area, but also there is reduction in gray matter volume in parahippocampal gyrus, fusiform gyrus, middle frontal gyrus and inferior temporal gyrus. And there is another sequencing like resting state functional MRI, where high resting state they are seen in the left lingual gyrus, right middle occipital gyrus, bilateral anterior cingulate gyrus, left middle occipital gyrus, bilateral paracentral gyrus, and low Reho value they have identified in the left inferior frontal gyrus. And this is a this is then treatment. Even you can do treatment by doing a transcranial direct stimulation by directly stimulating the primary visual cortex. Here you can see there is a increase in activity here by doing an anodal transcranial direct current stimulation. Here you can see the activity is similar. And even they have studied the effect of perceptual learning by doing a sequential functional MRI. They have identified the increased activation by the amblyopic area was found in Brodmann area 1719 and bilateral temporal lobes and right cingulate gyrus after perceptual learning treatment. You can see there is increase in the uptake after doing a perceptual learning. Basically, functional MRI is a very complex topic. Imaging in amblyopia has I don't know, you need a good radiologist for this. First of all, the functional MRI is not routinely done, and if it is done, the person doing it has to be very patient because it is a very long procedure. Usually MRI is done by technicians, so you need a good radiologist and a good institute. Routinely it is not available outside. Okay, thank you. Any doubts?
Any doubts, any questions?
So we can move on to the third presentation. Our third speaker is Dr. Deep Shikhar Das. So he was our senior resident, recently has completed, he has moved to West Bengal.
A very good afternoon everyone. Today my topic of this discussion is optical coherence tomography angiography in amblyopia. So it's basically OCTA in amblyopia. So what is OCTA? It's basically it's a non-contact imaging modality which uses tracing of red blood cells movements, and then it helps to emulate or form constructs an image. Okay, so using the movement of red blood cells we can trace the vasculature, and using that modality we have come across and able to differentiate different layers of retinal vasculature. So for example, we have this image on the leftmost side here. Yeah, this image, it shows the superficial retinal vasculature. This lies along the level of the retinal nerve fiber layer. Now coming to the second image, the center, this gives the retinal vasculature which is located in the middle aspect. Middle as in it's over the outer nuclear layer. And coming to the deeper capillary plexus, this is deeper retinal vasculature. It's located in between outer nuclear and outer plexiform and inner nuclear layer. So these terms I will be using later on and focusing mainly on them. So what is amblyopia? As we all know, it's nothing but decrease in visual acuity in one or more or both eyes due to abnormal binocular interaction or due to pattern vision deprivation during visual development, or for which no cause can be identified during routine ocular examination. However, if treated in appropriate time, it can give optimal results. So why OCTA was thought in the first place for managing or even diagnosing or any form of amblyopia management? So previously in 2009, Repka et al. Performed studies using OCT in anisometropic amblyopes. What he found was that the nerve fiber layer, not just the nerve fiber layer, the whole of the neurosensory retina was abnormal. Abnormal in the sense the thickness was varying. It was not normal compared to a normal control. But then again, the values were not substantial enough. So, and other than that, we have also moved on to the newer modalities like OCTA, using which we can actually trace the vasculature. So let's dive in. So what are the findings till now? There are total, we performed a review of literature where we were able to get 17 articles of OCTA, but then again, I will be just discussing on the retinal vasculature findings amongst amblyopes. So as we all know that there are three different types of amblyopia per se: strabismic, anisometropic, and bilateral, where ametropic amblyopia might be there. So these are the initial reports on OCTA. So Longi et al. Performed a study where he included 13 strabismic and 9 anisometropic eyes, and he found that there was reduced macular superficial capillary plexus and deep capillary plexus values, but then again, papillary, peripapillary vessel densities, FSZ area, and the foveal and parafoveal thickness were normal. Okay, this was done in 2016. At the same year, Guo et al. Performed another study which was almost having the similar parameters, like he included 13 anisometropic eyes and 9 strabismic amblyopic patients eyes. In that scenario, what happened? He found that there was no change. It was almost normal. There was no superficial capillary plexus or deep capillary plexus changes. However, he noted that the choriocapillaries, which lies underneath the retina, were a bit abnormal. I will be focusing on the subset of the article or the research with the maximum number of subset, that was Chen et al. By Chen et al., which included 85 eyes, of which 55 were anisometropic amblyopes, 16 were strabismic, and 17 were bilateral amblyopes. He found that there was significant decreased vessel densities along superficial capillary plexus. However, deep capillary plexus were normal. Anisometric patients were more severely affected than other forms of amblyopia. Coming to the next one, where the subset is, subset was 40, that was Dubois. He performed the study in 40 anisometropic amblyopic eyes. He was also able to decipher that significantly lower superficial capillary plexus as well as deep capillary plexus were noted, and but the foveal avascular zone was normal. Then again, Sinner et al. Performed another study using 37 anisometropic amblyopia eyes, and he found that except for the superior quadrant of superficial capillary plexus and the deep capillary plexus, there was no obvious abnormalities. So coming to our own experience at RP Center, Dr. Amar Pujari had conducted a study. He also found that there was no obvious superficial retinal vascular density changes or deep vascular density changes. So this is our own experience. Coming to what we have gained, like OCT, like normal OCT, OCTA can also predict some abnormal findings, like I already discussed, that the vascular plexuses which are located in the retina might be affected, may not be affected. So there is a variety of changes which have been documented. Not just that, when it comes to the management also, we have seen that in literature, a study was done by Guhen Hazar et al. They found that amblyopic eye retinal vascular density potentially increases after amblyopia treatment in specific regions of the retina. However, coming to the lacuna which is still existing, we can say that existing observation need to evolve. We need to understand how vasculature differs in different kind of amblyopia, and there is a need to learn why, because the question still remains there. And then what happens with treatment, because we have some data, but then again it's not reproduced, like it's not done in a larger scale. And also we need to find out people like amblyopes where they may be treatment responders or non-responders, and how it differs amongst them. Other lacunae include, like most of the studies had a smaller sample size, and amongst the smaller sample size, if we start to segregate them into different kinds of amblyopes, it will be further smaller, and we cannot like use it for a larger population. The ability to accurately assess the deeper retinal vasculature and choroidal vasculature are still evolving. Like OCTA is again in its early phases. Maybe in the next 5-6 years it will evolve further, and we will be able to see properly, like more clearly. Coming to the next point, OCTA noted retinochoroidal vasculature parameters varied varied with respect to many other confounders. Single conclusion from these studies is less accurate, that's why. And other than that, coming to our conclusion, we have been able to find that there are certain changes which are there in when we are talking about retinal vasculature, that is superficial capillary plexus, deep capillary plexus, papillary and peripapillary vascular densities and FAZ areas. However, those are never uniform. Few studies have stated that there are changes, there is reduction in those areas, but however, few studies have said that there are not. Okay, so we need to further, like we have to study further, and we have to continue this research forward so that we can come up with a better analysis and further use OCTA later on. Thank you. Anyone have any query? Okay, thank you.
So basically in amblyopia, if you want to image the eye, so basically you can go for the literature, you can search that, as Michael Ripka is one of the topmost name in the US who has done so many amblyopia studies. So he is a person who sets the guidelines in the US. So basically he began the initial imaging in amblyopia, and he said that there's a definite thinness of the retina in amblyopia eyes compared to the normal eyes. So similarly, subsequently till 2017, around 8 years, so many people conduct observations. So there were so many contradictory findings. Somebody said there is an increase in choroidal thickness, and somebody said yes, there is a decrease in RNFL thickness. But each person has their own explanation. If somebody says there is an increase in choroidal thickness, they say that yes, there is a dysgenetic choroidal vessels. That's why the choroid is disorganized. That's why it is thickened, and that's how the photoreceptors are going to derive nutrition from the choroidal vasculature. That's why your vision is low. Yes, he is correct. But at the same time, some other person says yes, I'm not able to find any choroidal abnormality. But Iranian people say that I am able to find a thinner RNFL. He says RNFL is not able to process, that's why vision is low. So in that manner, whoever has found a thinner macula or thinner RNFL or disorganized choroid, everybody is correct with respect to whatever the logical sense they have. So in the same manner, OCTA was came into existence in 2017 when Longi good paper was published in JAMA. But if you look into that paper, there's a large variety. only 13 patients were there. Like some patients had +6 hypermetropia and some patients are -12 myopia. So you cannot put all these eyes in one basket because I am ametrope. So if you are going to scan in both eyes, the things will be more accurate. Because OCT is such a sensitive instrument. If you have +7 signal strength and +10 signal strength, you have 10 eyes with +7 signal strength, and you have 10 eyes with +7 signal strength, 7 and 10. So you will get a statistical significant difference in vessel density with that one only. So if you have a larger axial length and smaller axial length, again it is going to be a brighter image in hypermetropic because eye is small. In myopia, it is very difficult to capture the retinal vasculature because the retina is thinned out, the vessels are thinned out. Obviously, the retina is going to show sparse retinal vessels. So there are so many drawbacks. So ultimately, again, people are able to give so many contradictory values. So I've written one more review in European Journal. But ultimately, if you ask me in future whether one should buy OCT angiography for to treat amblyopia or not, the answer is no, because it's not able to give any definite saying, because if you do it on a patient will say why I've done this one, and you cannot use that one for clinical purpose. You cannot say that yes, I want to give patching therapy based on OCTA findings. No, that is not true. Again, it is a quite expensive instrument and there are so many variabilities. So even like European countries, American countries are trying to find, because there are so many algorithms. There is a swept source OCT is there is a spectral domain OCT is there are so many limitations with respect to penetration, homogeneous guidelines, because it's all game with pixelation of the photograph. So if 10 pixels are more, much wider picture, obviously the results will be different. So in that sense, we need to explore in such a way that can I use OCT in some treatment aspect? So in the sense that after, like as Deep rightly said, after 4 or 5 years, if you gain other like 10 to 15 articles knowledge where people have given treatment, patching therapy or dioptics or whatever form of treatment you want to give that one, right? So at baseline you do OCT angiography, and people who improved just try to observe the findings. Which vessels are improving, like which circulation was exactly improving, and the patient who did not improve, what was the fault? It was the retinal vessels which did not get reorganized, or it's a choroidal vasculature. So in that sense, after like 5 to 10 years, we will be able to see, yes, probably this is a critical zone, retinal vessels, RNFL vessels or choroidal vessels, which are getting reorganized as shown by one of the articles, right? So in that sense, after like some years, if we are able to generate good data, then you can say that if you do initially, amblyopia patient has come, you do OCTA, probably we are able to give some key signs. Yes, this patient probably improves. Give patching therapy. Another patient, no, these are the OCTA findings which say that patient may not improve any vision. So in that sense, we should be using OCTA. That should be our ultimate goal. So then you can have a justification to buy instrument. Otherwise, just for research purpose, yes, our center, L. Prasad, Shankar Netrala, we have fund, we are going to purchase machine, but ultimately it's a question of clinical benefit, whether you can do some difference to the patients. So it's still in a research mode, but clinical role right now, you cannot use that machine to treat or just to say anything to the patient. But we are positive that with improving technology and AI in future, we'll be getting some knowledge which we can actually use for clinical planning, right? And as Dr. Sujit rightly said about MRI and CT scan, that is very extensive, that is very interesting topic also. So as I said, anterior portion can be visualized using OCT, simple OCT, and the posterior portion, because we are interested in muscle bellies, right? So it could be, again, so many people have done, again, these are all like research purpose, DRS, your CFM, your congenital CCDDs, cranial palsies, cranial hypoplasia, all these conditions, you cannot use that knowledge for surgical planning. Again, you'll be cutting the muscles and you'll be resuturing. But if you say there is a split LR, it doesn't make any sense. Yes, in myopic strabismus fixus, as he rightly said, there is a nasalized SR and inferior displaced LR. So in that case, you are going to do loop myopexy. In that case, you can say, you can justify yourself, yes, I am able to see there is a thinned out superiotemporal intermuscular septum. That's why I want to do a Yoko map procedure or loop myopexy, whatever you want to do, right? So in those cases, it has limited value. But otherwise, if you are like good clinician, if you have seen myopic strabismus 10 to 15 cases, eye is isotropic and hypotropic, it's not getting elevated, it's not getting abducted. That proves that yes, there is a deficient this thing, and axial length is of course 28 or 30 millimeter. That itself proves. So that's what Dr. Pradeep Sharma sir used to do. He used to do clinical planning based on whatever he is able to see. Of course, MRI studies are there, but these are able to give little values. Patients are poor. If you are going to ask them to pay 5,000 rupees, of course, it will be heavy for their pocket. And at the same time, functional MRI, dynamic MRI, these are again at research purpose. Functional MRI you can use for amblyopia, right? So, but you cannot say, of course, as I said, if one area was initially discovered, then V2 area, then calcarine sulcus. The things are moving. Now they have come to LGN, right? So ultimately, if you go into standard Hubel and Vessel experiment in 1979, so that itself says that the neurons are like shrunken at the cortical level. So even that's what we are seeing on functional MRI, right? So we are just using the same concept as a crucial cycle. So we are not getting anything new as far as treatment is concerned. Of course, we are making so much progress with respect to color imaging. We are going to get so many colorful images. And at the same time, dynamic MRI, where you are able to move the eyes and you are able to see whether tendon is or the muscle belly is actually contracting or relaxing. There's a misinnervation. Again, that will give some information for surgical planning. Then you can justify, yes, it gives me more understanding, right? So you can explore more also. In that case, you can order for dynamic MRI. And as you rightly said, there are very minimal people who are interested in doing ocular radiology. That's again toughest challenge, because the radiologist is not going to earn much by whatever the imaging is doing on your patients. They are more interested in intervention radiology, neurology, cardiology, your carotid artery embolization, those sort of things, because that is going to earn them good money, and that gives them, that's how they want to present. They cannot present a radiological finding in their radiology conference. Nobody will be interested, right? So we are fortunate in AIIMS, we have dedicated ocular radiologist, Professor Sanjay Sharma sir. So he does functional MRI and this thing. And in AIIMS, one, there is a functional MRI, dynamic MRI that is completely dedicated to thesis only. All sort of medicine, surgery, neurology, cardiology, all people are dedicated to that machine only. And that is not used for patient, that is only for research purpose. So we have still 15 days, 1 month waiting period. If I want to get one dynamic MRI done, I have to book 15 days or 1 month prior. So that sort of thing is happening. We are going to expect that in future, every center is going to come up with good technology and good radiology imaging process. So in that case, even you can try and you can get more conclusive evidences, right? So we can use, but basically what we want to say is, whatever the OCT and CT MRI we said, you got so many insights. So ultimately you should be asking one question, can I use this one for clinical treatment? That is the bottom line question, because if that is not able to make sense right now, you're going to say, I'm not going to use. You do more studies and let me know, right? Any doubts?
Any queries, any doubts? Otherwise, we can conclude the session. Thank you.
Thank you.
Thank you.